time.
Before you start, just one more thing. So what we have, Jenny is the administrative body that helps put us together, but you're talking to a very large health system in Thailand that is almost 50 hospitals across 3 countries, primarily in Thailand, but has a fabulous range of services across all levels of care. Dr. Surapon, who's actually on the call below, comes from the academic side and also works across both sectors. He's the lead of this. And Dr. Surapon, nice to see you. Your name, although we can't see your face, Sawadee Krap. And thank you all for presenting.
อาจารย์คะอาจารย์โชว์หน้าหน่อยไหมคะ Do you want to show your face, like the handsome face? Dr. Surapon คะ
He's thinking about it.
He's thinking about it.
All right.
Hello.
Well, maybe
hello, everybody. Hello, Richard.
Hi there. Good seeing you briefly. I did go look for you again 2 or 3 days straight. I couldn't find you again, but it was a good meeting.
Because it's 7 a.m. in Bangkok, so as soon as they wake up, they'll be on. So go ahead.
Yeah.
Anyway, what we'll do here, because usually what we try to do is we try to be, pay attention to time. We're going to try and do these presentations in 45 minutes, and then that leaves 10, 15 minutes for questions. And what will happen along the way is, afterward, if you have more questions, just contact us in the email. So we're going to try.
Yes.
Okay, before we start, because we did change the topic urgently, just inform our team that Dr. Richard just mentioned a while ago, like we have changed some topics, and then we have all the team from OHSU who are ready to like give us like the information, like all the great samples and like experience over the OHSU side. So just keep in mind that we are not talking about data today. We are talking about card detail today.
And I'm at wit's end again.
Okay. So I think
I'm sharing content. I'm trying to share content and it's coming. It looks like I have it on my screen. And
see it, Dr. Maziers.
Yeah, reshare it again. Stop it and reshare it again. Try that.
Yeah.
Okay, it's back.
Stop.
Oh.
You have it, and then it went away.
Wait a minute. Optimized for text and images. Screen. Window. Screen 2 is. I'm hitting screen 2. Is that black?
Okay, just hold on. It's coming.
And there's Dr. Surapon. Nice to see you, sir.
Yes. You can you see me? Huh?
Yes.
Yes.
Thank you for joining us. Good morning, sir.
Yeah.
Screen's just black.
Is the screen black or do you see the pictures?
It's black.
It's black.
Oh no.
Well,
this was working. We've been working this frequently. Uh-oh.
Send it to me.
I cannot see the screen. Richard.
Got it. I got it. That screwed up again. This happened.
Send it to me or maybe to somebody else and we can share it for you. May I share the PowerPoint with Jenny? Is that okay?
Yep. Please do.
Okay. May I share the PowerPoint? Is it okay with you if I share it with Jenny? Jenny, you can send the slides?
Yep.
It should be in your inbox. Maybe you could share it from your side and we can go from there.
Yep. 1 second. Okay.
Have it handy if we need to.
Anyone who has it, you can share it at first. I still haven't received it.
All right, let me see what I can do here.
You can do it, Karen.
I'm sure gonna try, y'all. I am sure gonna try.
We have all the fabulous people here.
What do you guys see that?
Sure do.
Yeah.
Go, good.
Oh, yeah.
Great.
Thank you.
Karen, you want me I can just say next when you want to click through the slide?
Yeah, and I think Dr. Maziarz, that means that I get to go to Thailand.
Yeah, so here's the, just to briefly mention, this is our 13th session for transplant cell therapy, and I wrote this as the critical function, the professional responsibilities, and how the nurse coordinator, specialist social work experts integrate in the care of patients with hematologic malignancies undergoing transplant and cell therapy. It includes Jackie Thurman and Bashi Roddery, who are nurse specialists in this field, and Karen McCord and Crystal Leak, who are social workers, and each of them the first of the two are transplant specialists, and the second of the two are the CAR T specialists. With that, next slide, and I'll turn it over to Jackie Thurman, who...
All right. Hi. All right. So I kind of just put together when patients come to us and then all the steps that we take to get them through to transplant and then return them back to the care of their primary oncologist. So first we start with the new consults. Those either come from external physicians. We have an intake center that takes these referrals, and then with the help of the transplant team, we figure out who is best suited to see them based on their diagnosis, based on the treatment they're referring them for. We do get internal consults from our treatment providers as well, and then they usually just come directly to us. For the autologous stem cell transplants, we see them in our clinic either in person or virtually. There is a new packet of information that we give to them at this visit. And some of the important things that we have to work with the physician with are answering questions like what type of treatment are they currently on, how many cycles do you want them to have, what's going to be their goal for collection. We ask questions like what type of pre-transplant testing do you want? Do you want PET scan, bone marrow, heart, lung function testing? We find out if the patients live close enough to Portland that they don't have to relocate, and if they do, where are they going to relocate? Are they going to come and stay in our family housing, or are they going to stay with family? We also talk about their caregivers and whether they have a good caregiver plan so that we can safely bring them through transplant. We also want to know if they have a central line or not. And then we start the process of communicating to the rest of the team what the next steps are. Oh, next one.
Hold on just a second.
Okay.
Of course, I thought I was being so smart.
All right. And I apologize if I talk fast. I'm going to try and slow down.
Actually, I wasted everybody's time, so you got to talk efficiently.
Yeah. Okay. So the new patient packet that we send to all of our patients includes this information. There's a financial document sheet that talks about their insurance. There's a letter from our social workers. We include maps of the campus. We always want to let people know what our child visitor policy is, and then there's a dental form that everyone has to fill out as well. So we give that to them early on. Next. This is an example of the communication tool that we use to communicate to our managed care team, to the physicians, to social work. So we fill this template out for each new patient, and that's kind of how we get the ball rolling with getting them through transplant. Next. If we see an allo consult, there are a couple of more specific questions that we ask them. Do they have siblings? Can we contact them to see if they would potentially want to be a donor? We would talk to the patient about HLA typing, and if they're there in clinic, we would do that then. And then same sort of questions, talking about where they're at in their chemo cycles. Do they have a line? Do they need to relocate? Will they have a caregiver? And then it would be the same thing. We would start this process by sending this email template out to our team, and then start working on all the steps to get them through transplant. with the siblings, there is a lot of other information that we have to gather so that the doctors can then determine whether they would be an appropriate donor or not. And so there's specific questionnaires that we send out. And then we do have a special team that is just donor coordinators that work directly with the siblings to gather information for us and work with the HLA typing. It's another resource that we have for our group. And this is just an example of the template that we send out that's specific to allo transplant and how we communicate with the whole team. And then once we know what the plan is, we've communicated that with the patient. The nurse coordinator has worked with the doctor to come up with a plan. We put together a calendar, and then we begin the part of the pre-transplant testing, planning out the consent visit. We order lines, we schedule the lines, we make sure that they have mobilization appointments. All of the treatment plans are entered and signed, the chemo appointments. We make sure that their bed reservation is in place. There's lots of communication amongst our cell therapy lab and the inpatient transplant team. Lots of different check marks that we have to get through to make sure that we get everything done prior to the patient admitting to the hospital for their transplant. There's also class that we offer that we teach via WebEx, and then just making sure that all their lodging is arranged and their caregiver plan is in place. So those are just some of the things that we together. This is an example of a tool that we use with our team to put all of those appointments in place. It's a message that we use through Epic, which is our electronic health record. This is just an example of what we send out there once we have this plan in place and how we request these visits. We put it out like this, and then the next slide. Oh, Jenny raised her hand.
I was just wondering about the consents form, because I think Kun Parani did mention about like we would like to have some samples of like the consents from, like, do you give like patient certain consent form to send?
Yes, and I do. There is a slide about that.
Okay, cool.
Coming up. Yep. And so then this is an example of just the itinerary that we provide to our patients so that everything is scheduled. We spend a lot of time educating them, going over their appointments, where they go, where they need to be, what they're for. And this is an example of the document that we would send out to our patients. So for the consent visit for auto transplants, these are the specific consents that we have prepped for us. So there's the actual stem cell collection consent, a blood transfusion consent, and then depending on what prep regimen they're going to get, melphalan, beam, we have those consents. We also have a database consent, and then there is an admission checklist that we also give. So we get all these prepped to give to the physician at that consent visit. And then for allo transplants, same basic consents, a couple of different ones that are used for donors. But I'm sure we can provide you, Dr. Maziarz, if they want the actual consents. I don't know.
พี่ไก่คะ I'm sorry คุณพานีคะ
ค่ะ
Is there any consent that we still want help from OHSU side?
Yes, but lots of some information I need like example from OSSU.
So are they?
We have lots of consents that we use, and then they're all blank with no patient identification on them, and then we prep them for the consent visit. So I don't know, Dr. Maziarz, if that's something that we could provide them.
Absolutely. We can gather a packet of information and send some, PDFs over the next 2 weeks after the visit.
Mm-hmm.
Okay?
Okay, well, I'll put the request as an email to you after this call, and then we might ask help from OHSU side on this one.
Absolutely.
Okay. And then specific donor consents that we use, we always have the donor's consent with a different provider other than the primary transplant physician. Just a listing of all of the different testing labs, documents that we need prior to the donor consents. And then just briefly, there's a whole process that we use, a whole algorithm that we follow, and a chart for when we are covering stem cell collections. There are different ways that we mobilize stem cells here. We either do just with the standard growth factor, sometimes we do double growth factor, and sometimes we do chemomobilization. And then donors as well will mobilize their cells before we collect. Next. This just talks a little bit about the donor process and for their collection and the goal and how we communicate around stem cell collections. We do use a lot of communication with the team to let them know when the process is complete. So this is just an example of how we would communicate with our entire team that the patient has collected enough cells and what the next step is in their transplant process. Again, just more examples of the communication that we use. These are what we call cryo orders, and these are documents that we complete and then send to our cell therapy lab, and then they then work with the physicians to put together what we call cryo orders. And then the last step before the patient admits for their transplant is another communication tool to the inpatient team, to inpatient social workers, cell lab, the MDs, the APPs, everyone. We send this final email before the patient admits and just lets everyone know what action needs to be taken, you know, any questions or concerns. This gets sent out. And then lastly, once they have discharged from the hospital, they're followed in our clinic for a specific amount of time. And then once it's, you know, time for them to return back to their primary oncologist, we have a return to care packet of information that we send out that I'm sure we could provide to you all. But it has information on all of these sections as far as what we recommend. And we send that back to their primary oncologist and they go back home. And that's it.
Dr. Maziers, do you want to pause for questions, or do you want to go straight to Bashi?
Well, I was going to go right to Bashi, but I was going to, you know, get all the questions at once. But just one last thing, and I'll probably ask each of you this individually. So, Jackie, can you share with the team how many patients, new patients a week that you are managing, and how many patients do you think total, you know, are you managing between the different doctors? With all the, because you showed a lot of tools and a lot of communications, we depend on the coordination of the activity. And so how many people are you, patients are you handling?
Right. Well, I just counted. I keep a binder of all of my active patients that I have to keep an eye on every day. And I have 25 right now. I'd say, you know, I mean, with each provider, you know, we have, it fluctuates. Sometimes, you know, Dr. Maziers has 20 active patients and sometimes it's 10, and then the next week it's 25, and it varies a lot. There's a lot of patients.
But I just want to say that because I think it's a critical role for our functioning is the team members that you're hearing do basically make the program work. Because if it was up to me, as you can tell, I can't even get a form to you on time, that none of this would happen. So thanks.
It's a lot.
Let me go on then to our next individual, which is next slide. This is, you know, so talking about CAR T therapy, I'm going to turn it over to Bashi to share her role as nurse specialist, you know, in the new world of cell therapy.
Thank you, Dr. Maziers. So hello, everybody. I have the pleasure of being part of the CAR T program. It's an exciting place to be for sure. And I recently made this slide just to kind of give an overall picture of what it means to take care of these patients. And it truly does take a village. We have the patient and their family. We do support their families as well in the center. And each of these bubbles that I have on there share an equal part in taking care of this patient. So, you know, we have our physicians, of course, who put the plans in place. We have our nurse coordinators, we have care coordinators, we have advanced practice members who hugely take care of these patients, especially afterwards, after the CAR-T infusions. So our nurse practitioners, our physician's assistants. We work with the research team. We have a number of clinical trials that we are running for CAR-T. Initially our nurse navigators also who help with that piece Jackie mentioned when we have patients coming in from external, outside of OHSU. They definitely help navigate the patient's care. They help provide records and make sure that they know where they need to go and introduce them to the team. Medical assistants, of course, and then we work with our surgical team, radiologists, radiation oncology. So the list is definitely quite long. It does take quite the team to get these patients through. So this is very similar to Jackie's first slide. Our external consults for new patients come to our providers for CAR-T or second opinion. And just like Jackie mentioned, we have now 9 CAR-T providers. So the decision is made among the group as far as who would be the best depending on diagnosis and timing. And if it's an internal consult, we just have a referral sent to one of our providers, and usually the providers speak to each other and refer patients over for CAR-T. So prior to collection, CAR-T is a little bit different than auto and allo transplant. It is a little bit split. So before collection, we do need confirmation of, again, which product to use, when to collect. We do check for CD9 positivity for the lymphoma products in particular. We have insurance authorization, which can sometimes cause a problem. And then we do confirm that patients have caregivers. If they need to relocate to Portland, as Jackie mentioned, with those patients, it's the same for CAR-T. We do help them with travel and lodging. And then to ensure that they are not allowed to drive for 8 weeks after the CAR-T infusion. So in the beginning, we do coordinate the vein check to arrange for line placement if they need a collection line for the cells. We arrange for the visit with the physician for the consenting, and we have our own separate consents for CAR-T. We have our own separate CAR-T labs, and then we do watch for washout periods for medications. And then we do the CAR-T collection and shipment to the manufacturer. And this is just a guideline that we use for washout periods that we just completed to spell out what drugs we need held before collection. And along these lines too, I will add, we use the same templates and forms that you just saw Jackie use as well for auto and allo. Ours are just a little bit geared towards CAR-T, but very similar. So the evaluations needed, again, those are also very similar. These all must be done at least prior to CAR-T infusion. Sometimes these patients are coming so fast and furious, we need to get them in for collection right away. So we will hold off on tests such as pulmonary function tests. Sometimes scans we'll do later, echocardiograms. We try to get the collection done first, and then we work on all of these pieces. Cell return can be anywhere from 2 weeks, like a Novartis product, to 8 weeks, like our new Carvykti product. And the evaluations include the social work evaluation, echocardiogram, EKG, pulmonary function tests, always a scan, usually a PET scan, but they may also need an MRI of the brain, for instance, or some other type of scan. And then some patients do require bone marrow biopsies or lumbar punctures. And again, we have another separate washout, very similar to collection, slight differences for the washout before chemotherapy, the lymphodepleting chemotherapy. So oftentimes our patients can't wait that amount of time before the cell returns. So we do bridge them with some chemotherapy and treatment, and we need a washout before we start the lymphodepleting chemotherapy for CAR-T. And we set up the CAR-T infusion. We always have another visit with a physician for a second consent and evaluation to make sure that they are ready to go for the CAR-T infusion. We do still test for COVID before we do our lymphodepleting chemotherapy. The agents that we use are either fludarabine and Cytoxan together or bendamustine alone. And we arrange for the inpatient admission either for the next day of CAR-T cells, or we can do an outpatient infusion. Currently, we are only doing that with the Novartis product, but soon to come, we are trying to move some of our products to the outpatient side. And again, we help patients with travel and lodging support if they need that. And then post-CAR T, this is really where our evaluations and assessments come into play, and we monitor these patients very closely. It's always daily for the first 7 days. Oftentimes, much of that is on the inpatient side. And then every other day for days 8 through 14, every third day for days 15 through 29, which gets them up to their day 30 restaging. Every visit includes evaluations for the cytokine release syndrome and the ICANS. And we have an infusion appointment for all the replacements they may need, the blood, electrolytes, fluids. And then we have our labs listed below that we run for all of our patients. And we have our big assessments at day 30, 90, 180 in particular. The day 60 is just a quick visit with the physician and some labs, but the other days we do usually repeat a scan or anything else that they may need for restaging. And then we have our special CAR T, additional labs, and a visit with provider. And then we do the same once they're ready. We rehome them or return them to their primary oncologist. And we send out a letter with all of our recommendations as the ones we've listed below.
So then I'll ask the same question then, and also recognizing, and you can comment on the difference between transplants where transplant tends to be elective. CAR T is often very urgent for some of the patients. And how many patients are you currently managing, coordinating, and where do you see the greatest bottlenecks and what causes you stress on a daily basis?
I am up to about 40 patients currently in different various parts of the CAR T process. And I will say for sure the bottleneck is just access to healthcare. It has been amazing. I think we felt it when COVID first hit, and I was hopeful that it would ease up a little bit, but we are still finding the same bottlenecks. An example is our echocardiograms are booked out at least until June, and that includes all of our neighboring hospitals as well. And we just heard today, I think our bone marrow biopsies are next available in June. So when we have these patients who are coming in so quickly and needing this treatment so urgently, it is really difficult to get everything in place on time. So we fight hard to get our patients through.
And we usually manage, but it's just it's also just emphasizing that this is under the amount of work that goes between these offices is immense and is often underappreciated. And my only work is trying to bring in more patients and create more chaos. So anyways, I want to turn it over now to regarding I've called non-medical needs. Social work does provide care, and a lot of it is absolutely medical. It's probably bad terminology, but let me turn this over then to Karen and Carissa to share their thoughts on their roles.
First of all, thank you all for letting us come and speak with you today. I guess before I start, one of the things that I really value about the way we offer care to patients at OHSU is it is a very interdisciplinary team. So social workers, nurses, physicians, nurse practitioners, we all really come together and care for our team, care for our patients as a team, and I really value that. So in terms of the scope of practice, specifically for oncology social work, we really function at a micro, a macro, and a meso level. And these are just some of the examples that we do in each of those domains. So kind of for our patients, their families, and our caregivers, we're really providing, or we hope to provide, comprehensive psychosocial services. We're very fortunate to have a robust patient and family service department where we have social workers, we have massage therapy, we have acupuncture. We are in a very special place at OHSU that we can provide so many services. We're also working within our institution and other agencies to continue to increase our knowledge, but also talk to folks within our organization about the psychosocial, the cultural, the spiritual needs of our patients and the effects that this has on them so that they are treated holistically throughout our institution. We do a lot of education with members in our community. And then some of us take on roles within our profession to sort of bring up the next generation of oncology social workers. But specifically, the role of the bone marrow transplant social worker and the CAR T cell social worker, specifically what we're focusing on is just helping people adjust to this diagnosis, adjust to this treatment plan. We participate in a lot of communication, navigation with patients and families with their medical team. We might sit in on appointments with certain patients. Sometimes I'll often act as a scribe for patients who just need to listen to what the physician is saying, and I'll take notes and then put those in terms where I know the patient can kind of digest it later. We offer mental health recommendations and referrals. Some patients we have the opportunity to do some short-term counseling with, which is nice. We also refer out to any community-based services that might help our patients. We do a lot of grief and loss and bereavement support. We help mediate family conflict. We help navigate OHSU. We do a lot of work around advanced care planning. So helping people think about what would they want in terms of how much aggressive medical care would they want if they were very ill. And we do get involved if there are end-of-life issues where someone disease has recurred. We're now talking about a change in goals of care. That's a big part of our role. And then we also do a lot of information referral with our financial counselors, which we're fortunate to have. And we talk to our folks about any insurance concerns. I've been with the program now 17 years. And when we first started, well, even before I came, we had one social worker who covered the clinic and the hospital. And then we thought it was a really big deal when we went up to 2. I am really proud to say that we have grown, and currently our bone marrow transplant and heme malignancy program has a really robust social work group. We have 2 social workers in the outpatient setting. One social worker, who is Carissa, who's going to speak to in a moment, is committed just to CAR T, and she goes both inpatient and outpatient and follows those folks specifically. And then there's a typo in this. I apologize. We have 2 social workers who work on our bone marrow transplant unit, and they go wherever our patients go in the hospital. So if they have to go to the ICU, those social workers follow them in the ICU. So we're fortunate to have so many folks. I'm going to turn it over. Chris, you want to take the assessment?
So part of the work that we do with each and every patient who comes through OHSU for an auto, allo, or CAR T procedure is this psychosocial screening, as to assess for any needs, to ensure that they are ready to move forward. So we cover demographics. It's helpful for us to know, like, who is a part of this person's family. Are they married? Where are they living? Are there any specific legal issues that are going on? Like, are they in the middle of a divorce? Is there custody concerns? And then, do they have children at home? Is there work that we need to do to help them prepare their children or other family members or other people they're responsible for? Certainly that also goes for like multi-generational families. So folks who both are caring for children and older family members who need a lot of extra support. So helping them navigate their resources and access to that. We ask about employment, financial information. Is somebody on disability? Do they need to apply for disability? What's their source of income? Are they the primary wage earner, or is the primary wage earner of the family their caregiver, or are they both going to have to lose income to move forward with transplant? Are they insured? Are they insured enough? How much money are they going to need to pay out of pocket? And I acknowledge that some of this is very specific to like the US healthcare system. One of the things that we have to make sure our patients have access to is prescription coverage, because the outpatient prescriptions for transplant are just astronomically expensive. Are they able to maintain the insurance and income or other sources of funding that they have? And then, are there other things that we need to address? Like, do they need to do any financial planning? Are there any other areas where they have a lot of of their financial assets going toward. Do they have a financial power of attorney, or do they need to assign someone? Another big part of this assessment is, talking through sort of where they're at with their cognitive processing. Are there any deficits? What's their health literacy look like? Do they really understand what's going on in their care? Do they need a little bit of extra support with that? How do they learn about all of this? Like somebody who needs things in writing, is it helpful for us to give them videos? Do they need a family member, or like Karen mentioned, sometimes we'll scribe? Do they need us to really be engaging with them in a specific way for their learning? We also address their mental health history. Did they come to us on any medications for that? Are they experiencing significant anxiety, depression? Do they have a severe and persistent mental illness, or something that like a bipolar disorder that may be exacerbated when we start giving steroids after an allo transplant? And so we'll get all of that assessed first so that we know how we can best support our patients moving forward. We'll check to see if they've had counseling in the past, if they're interested in that, or if there are any significant recent stressors that they've been through that may impact sort of how they're moving through this process. We're also looking at where do they have really excellent skills to navigate this? Where might they need a little bit of extra support from us or their caregivers or the people in their lives who are supporting them? What are their coping mechanisms? What's worked for them in the past? Are there things that, are there behaviors that they're engaging in that we're noticing, like they're avoiding certain parts of care? Are they not showing up to clinic? And what are the barriers for that? Are there any alternative or complementary treatments that they're engaging in? Often patients will tell us that. Sometimes they'll tell their teams, but I don't know about you, Karen, but I find that often patients will be like, oh, by the way, I'm doing this alternative therapy, or, I'm going down to, South America for like an ayahuasca retreat or something. And like, we communicate that to our teams. And then how are they adapting to and navigating and integrating their illness into their lives? And, are there areas that we could help them do that? Or are they doing a really, excellent job of doing that? Certainly a huge part of this is like, who is surrounding our patients to make this a doable process? Like, do they have a partner? Is this a good relationship? Is this a supportive relationship? Is this somebody who is going to be able to support them? Or is it somebody who we need to know is in their lives and is, probably not going to be an integral part of this process? And then, who else is involved in this person's life that can help them navigate this, can help them get through transplant, CAR T-cell therapy? Certainly, who are the caregivers? Who's going to be with this person for 30, 90 plus days? How do they all work together? How are the families and caregivers navigating and adapting to, these changes happening in their lives? Who are their spiritual leaders? Who are their faith-based supports? Where are they coming to us from culturally? How can we best support them in our system? And who can we leverage in their communities to make sure that we're meeting our patients who are coming to us from different cultural traditions? And then we also help identify, certainly, and want to know who they're accessing for informal and community supports. And then certainly a large part of this is like our general assessment of, does this person understand what a transplant is, what CAR T is? Like, have they been taking in the information that we're giving them? And sometimes like that's just a feeling that we get. And Karen and I often will ask in these interviews, can you tell us what you understand so far about your transplant plan or your CAR T-cell therapy plan? Are they having trouble making decisions? Or, Karen mentioned, like, we'll often help patients and their families decide, like, or determine for them what the level of healthcare, is that they want to participate in, right? Like, do they want to move forward with a transplant? Is that within their values of, what's important to them and how they live their lives and what's next for them? Is their pain managed? What are their expectations? Where are they finding hope? And then certainly their ability to make plans for after and during transplant. And then, like Karen mentioned before, we do a lot of advanced care planning, advanced directives, helping determine what's important. So this is our form that we use. So it's a lot less wordy than that. So the previous thing are some of the things that we keep in mind as we go through this, but this is what we document in the record. So we're looking at all of these different things. We have, I think, both of us kind of a script that we use to go through this, and then we make recommendations at the end, and this goes into the patient's medical record and sometimes to an insurance company. So specifically for transplant or CAR T-cell therapy, our patients must have a caregiver or they cannot move forward with transplant. It's just not safe. Our insurance companies do not cover a caregiver, nor do they cover any sort of wages or lost income for patients like family or friends who are doing caregiving. So typically it ends up being people in our patients' lives who step up and do this, whether it's one individual person or a team of people. It is an incredible commitment. It often means a lot of time away from other personal responsibilities and can be really disruptive for people's lives. So for auto transplant, typically 2 to 3 weeks after discharge from the hospital. For an allo transplant, typically we'll say we need someone with you for that first 100 days. Some of that time is in the hospital. Sometimes that's a little bit longer depending on how a patient tolerates the transplant or if they have complications or graft versus host disease. And CAR T-cell therapy, that's at least until day 30. A few of those days will be in the hospital, but afterward until day 30. And then for all of our transplants, we require our patients to be specific distance away from OHSU. So for auto transplant, CAR T-cell therapy within 1 hour until day 30, and then allo transplant patients and their caregivers must be within 25 miles of OHSU until at least day 100.
I'll just point out, you saw Karen presented that we have 5 social workers. Just to put a volume in place, we're probably between 250 and 300 transplants that have taken place at OHSU. Probably between 70 and 80, probably closer to 80 CAR T procedures and cell therapy procedures. So that's already getting close to 400, 350 to 400 people. But it also doesn't count the people that we start and the disease doesn't let them get the transplant. There's a lot of more, there's many, many more patients, when you add to the burden of who we're caring for that actually don't get the transplant. And so you can actually figure it a factor of maybe a third, another 30% worth of activity. So this team does a lot. We all recognize, the slide showing all the people that Bashi showed, showing all the different services, everybody, it takes a lot of people to run this. And it's very gratifying to have the ability to have taken this many patients through and have basically contributed positively to a lot of people's lives. Not everybody survives or not everybody finds it a positive experience, but in general, the group works together. Anyway, this is an opportunity though to ask for whoever's on the calls to ask these, what you want to ask them directly.
So I think that the social worker is very much important for the success of transplantation and CAR-T. However, because we haven't transplanted a lot in our center, we probably need the specific social worker to work like you. So far, the nurse coordinator work for these responsibilities.
And, Dr. Sarapal, am I saying your name correctly, sir?
Pardon me?
All right, Dr. Sarapal, is that correct?
Yes. Yes.
Okay. Something that we didn't put on our slide deck, but I do think it's a big part of what we wind up doing. We also wind up supporting a lot of our staff, whether that's our physicians who are working so hard to keep these patients going. We certainly spend a lot of time with our nursing staff. And so it's an honor to work with these teams and work with these patients and families, but I do value the time that we get to be in support of the people that we work with as well.
Yes. I very much realize how important you are, how important social worker is. So we have to set up the full system to have our social worker in our team.
Thank you for saying that.
Yeah, and I was going to say is the other value of our nurse specialist team and our social work team is, I have many patients, but patients actually sometimes want to please me. I'm trying to help them, but they don't want to let me know the stress that's going on because they think I'm helping them fight their disease. And the important ability to have, a trusting relationships for patients with the social work team and the nurse specialists, that becomes a major resource to the patients that's also under-recognized and doesn't get enough credit for the importance it plays on the overall outcome of the patient.
I've actually had a lot of Dr. Maziar's as patients. They're very honored to have Dr. Maziar's be their transplant physician. And a lot of them don't want to let Dr. Maziar's down. And so they will actually talk to me or Jackie about, well, I really am thinking about this, but I just don't want to let Dr. Maziar's down because he's worked so hard for me. So I appreciate you naming that, Dr. Maziar's. It is true. Patients have such honor and respect for doctors.
Yes. Sorry, Karen, I didn't mean to cut you off. I was going to emphasize that point in Thai society too. I think in Thailand, they're very polite culture. But I think having practiced for 20 years, 5 of which in Asia, I think that first of all, social workers, if my social work, because they were more important than my work, because without the social work team, there was no point in work. But I think that having a place to go in Thailand to share some of the sort of personal stories would be really helpful because there's such a polite relationship between physician and the physician-patient relationship. I think that's a really good point you're making, Dr. Surapon, and to have that aspect of your team, if you don't have it already, would be an enormous, I think, comfort for your patients.
Yeah, I think so. I very much agree with you. Yeah.
And I think that, we talked a lot about this time patients doing the psychosocial assessment, and the way that Karen and I are presenting this isn't a list and I'm checking boxes as I go down. We're having a dialogue with patients where, we're joking around with them. We're setting up this relationship and building rapport during this hour plus amount of time that we spend with our patients that we're hoping carries through. And so our patients really feel like we're approaching them as whole human beings, right? I often will say in this eval, you can spend a lot of time reading your chart and finding out what's been happening with you medically. But what I really want to know in this conversation is who you are and how we can best support you. And I think that makes people engage more fully in the whole system here. So I think that is just a super valuable part of this, because I think that we're building rapport, certainly, but I think it also helps to have our patients build the institution as a whole.
I'm interested in your role also in evaluating the psychological status of the patients.
Mm-hmm.
Would you tell me in more detail?
Like how we assess that, Dr. Surapal?
I am interested in your function
Oh,
in assessing psychological status of the patient. That is fine.
Yeah, so I think we definitely look at certain tools, and we can send you those tools that I think Carissa and I kind of know in the back of our heads what we're doing, but there are formal tools for depression and anxiety that, again, we're not going through a rote way, but we are asking the questions, and we're then able to assess, is this a really situational depression, a situational anxiety, or is this an undiagnosed mental health disorder? We are fortunate in just the last couple of years we have cultivated a couple of our psychiatrists who are now embedded in our clinic. And so we can consult with our psychiatry team if we have concerns that there's a more kind of untreated or active psychiatric issue. But what I have found is a lot of times what people will tell me is very situational. It's an extremely appropriate response to their diagnosis, their treatment, living up to transplant. But then what it offers us is this opportunity to talk about, hey, it sounds like you're depressed, you're not really getting out of bed. Like you're going and putting the covers over your head, or it sounds like you have such intrusive thoughts that you're not sleeping well. And then we have this opportunity, Carissa and I, in these psychosocial evaluations, to start like developing a treatment plan with them for their mental health. It is pretty rare, and Dr. Maziers, you can correct me if I'm wrong, it is pretty rare that we have a hard stop for going to transplant based on a mental health diagnosis. We work incredibly hard to take our folks to help them manage their distress or their mental health issues to get them through transplant. But I'd certainly be happy to send, and you may have access to this, but the PHQ-9 and the GAD are the main tools that we use to assess depression and anxiety in our patients.
Thank you.
I don't know if those tools are like cross-tested in Thai.
Good point.
But like, I wonder if there are some of those tools, or if they have been cross-tested for language. So I would make sure about that. The other thing that I think we see a number of patients who come to us like with a history, like documented of, a mental health diagnosis. Often patients have been engaging for years in their mental health care and kind of know what that looks like and know what they need. Certainly, I think the new diagnoses that we see are the short-term temporary ones where people are saying, like, this is a lot to deal with, or I'm facing my mortality, or, I'm really anxious about getting a bone marrow biopsy. How do I cope with that? Or like, I don't like people touching me in the hospital. Like, so we help navigate like what a good plan is for that. And then, the handful of patients that we get through who really have unmanaged, like uncontrolled mental health, like that's where we can really community resources and our system resources to try and get folks through. But that's a little bit more involved and harder.
Yeah. The other thing I would just say, which is an observation, is that
I can't hear you.
We lost you.
Richard, I can hear you.
You're on mute, Richard.
I can't hear you.
How we preface that? The most important thing I want to say is, and then he cuts out.
patients, saying,
We lost you there.
me or
Yes, we lost you. Can you go back to where you said the most important thing I want to say is?
Oh, I said the most important thing is I want to say is that, when a patient, we've heard a lot about how we manage them here at OHSU and how the teams work together. I think, and also and you heard a lot about the relationships that are built between our nurse specialists and our social workers with the patients. I think one thing that we didn't really highlight is what happens when a patient goes back. So I get follow-ups. I may see a patient every 2 to 3 months. I may hear from their doctor, but the patients, really build a relationship here. And I mean, these guys can tell you about how often the patients are reaching out and want to make sure they doing the right job. I mean, Jackie and I share a patient who lives in Hawaii 6 or 8 months a year. And I don't know how many times Jackie is, how many times a week she's hearing from our patient about, are they doing the right thing in Hawaii? But it's another bit of that relationship that builds. You also have to meet the needs. You don't want to just wash your hands of a patient when you're not taking care of them anymore.
Good.
One last thing, I know we're, but I think the other thing that we have gotten much better about in our program is caring for people who live with the comorbidity of substance use disorder. So people who are coming to us with, active methamphetamine use, active heroin use. For a long time, that was words, absolutely not. You can't be using. We have been pairing up with providers at OHSU who are specializing in addiction treatment, and we've really been working on cultivating that relationship to hopefully take on, for example, Suboxone possibly, to see if they can get their substance use disorder better managed, and hopefully get to a place where that won't be like, you're using, you can't go to transplant. Now, we have a tremendous amount of responsibility to these patients and their safety. So we are putting central lines in these folks, and we have to be careful that, the way you assess for that is fascinating. So that could be a whole nother topic, but I'm excited to see some of our bias start to shift about how we take these folks to transplant.
Good.
So as we come close to the end of the hour, or are there other final comments from anyone want to ask or make comments in general? And certainly we can continue these sort of dialogues.
Yes, I think this is very important. Nurse coordinators and the social worker, and we have to set up this systematically in our unit.
One of the questions that I think you sent out, Dr. Maziarz, was about child life, and that there's no specific sort of degree or career path for child life in Thailand. And Karen and I were talking a bit about that. We are not child life specialists, Karen nor I. We have those colleagues in the hospital, but I would say that we do a significant amount of work as social workers with helping parents or grandparents or, people who are guardians of young children navigate serious illness, navigate end-of-life issues. So while we don't have those specific degrees ourselves, and we do have colleagues, I don't think that the ability for a program like this to run hinges on access to child life. But I do think that it would be important for any social worker who's working within your program to be able to engage parents and their children in serious illness and in end-of-life issues.
Yeah, they were just interested because there's adult hospitals, but there are 2 pediatric hospitals in Bangkok, and so they were specifically interested in that concept. So that's going to be that will be a future discussion.
Oh, it's very cool. We love our child life specialists.
Thank you.
But I'm also glad I'm not one.
All right. Well, if there's nothing else now, I want to actually thank my team members who really, took this opportunity very seriously to put together a program that would be, informative, educational, and also try to be as globally inclusive of what their experience is and what their roles are and how they function. I think it's like I said, we can't function without them. and we will certainly be willing to, as before, communicate tools or documents or things that would make your life easier in Bangkok and your other hospitals to, bring together and build that or continue to build this collaboration between our sites.
Dr. Maziers, and I guess I just want to, maybe it should go through you, but if anyone has other specific questions for me, Carissa, Bashi, or Jackie, I don't want to speak for everybody, but you'd be welcome to give our emails or any ways that we can be supportive.
Great, we'll do that. All right, everybody. And
thank you very much.
Jenny, you and I will be in touch.
I will pin it.
We will work very hard to build up the agenda for the next 4 weeks and get everything else you would like.
Thank you.
Bye, everyone. Thank you.
Thank you.
Thank you so much.
Thank you. Thank you. See you.